Welcome everybody, welcome back to the podcast. It gives me great pleasure to introduce you to a special guest for today, Dr. Mark Graham, who is a GP and works in dermatology. Welcome, Mark.
Hello, lovely to be here.
Well, it's really great, and we've got an interesting topic here, which I wonder whether people would expect to learn about as part of primary care, but we encounter it a lot. We're going to be talking about red legs. First off, Mark, I'm so glad to have gained your expertise for today. Would you like to introduce yourself?
Yeah, so I'm a GP. I work in Nottingham, inner city, and I've worked in dermatology for 9 years now. I'm not yet a GPSI, but I'm nearly there. It's more portfolio, and you know when you finish your GP training, you just think, do I want to do more portfolio? And I thought, I'll give it a bit of a break. And then 9 years later, I'm still being an associate specialist or something like that, or a clinical assistant or something. But yeah.
And that's working in secondary care as well in Chesterfield Hospital?
Yes, yeah.
Brilliant. Well, so I mean, let's start off with, so we're talking about red legs today. Why are we talking about red legs?
Oh, so I remember, when I first started in GP, it was something I think I'd see a lot. It's normally Friday afternoon, you get a call from district nurses saying, Doris has got cellulitis again, her legs are leaking, her legs are red. It's maybe less than it used to be, but quite a frequent referral to dermatology as well. And I think it can be one of those things that is misdiagnosed and mismanaged. And I think, it can be done better. We can improve. We can do better.
Yeah.
There we are. Yeah.
I mean, I would definitely agree with that. I think I probably get a question about this more or less every day of my practice. And I guess that the typical situation would be a message comes in from the district nurses and said, this lady has got red legs, they're leaking, or perhaps from a carer, can you send us some antibiotics? That's often what we'll get, or can you go and see her? Common situation. What would be your suggestion of how we start to approach that?
So I often think backwards, which is kind of annoying for lots of people, but I'm thinking, right, what are my potential diagnoses? So, if we think antibiotics, what we're thinking is this cellulitis. My other consideration then, well, is this venous eczema? Is this stasis eczema? Could this be a DVT? Could it be arterial insufficiency? I suppose if we're talking about kind of a red leg, probably not arterial insufficiency, but that's kind of always there. And yeah, as always, I always want more information, and I think that's always the key. If you get an email from district nurses, I always want to talk to them, because I think often you get an email just saying, can I have some antibiotics? And, I always want to know quite a bit more, which I think irritates people, but it's one of my many flaws. Yeah.
Well, I think it's good to ask more questions, certainly, and I think the temptation is, especially with busy general practice, that this can be quite a time-consuming problem, but really important. Just not only from an antimicrobial stewardship point of view, and of course we know that antibiotic resistance going up, and of course we have risks of C. diff and similar things like this, but also making sure that the patient's being treated for the right thing.
Yes, exactly, and I think sometimes it is obviously really easy to say, yeah, just have some antibiotics, go away. But I remember there was one lady, I think there was several times when I was on call, there was a call over multiple weeks where it was kind of some antibiotics for this cellulitis, and actually, when we got to the bottom of it, it wasn't cellulitis. So we've been mismanaging it for a while, So when I'm approaching this, I always kind of think about, the key things to me that differentiate are when we think about cellulitis. So bilateral leg cellulitis is rare. It's really rare. So then you're telling me you've got two separate infections in two separate limbs. That's really uncommon. That's the key thing for me. Cellulitis is hot. So if you've got two legs that are red, but they are normal skin warmth or cold, I don't mean cold blue, arterial insufficiency. If they're normal skin temperature, this probably isn't cellulitis. And also, if this has been going on for a long time, then again, that kind of goes against it as well. So that's the key things for me. They're to me, the most important things.
Sure. So one leg or two is a really good place to start. Okay, we've established it's both legs, so I guess we're moving away from the cellulitis aspect of things. Where next?
Where next? So I think probably it's, if, again, we're busy, we've got things to do, we can't be visiting everybody, but in an ideal world, that's what we'll be doing. But actually, I think sometimes it's probably good to invest that time early on and say, right, let's go and have a look and see what's happening. Because if, I think often with patients where you're getting an email to just saying antibiotics, that's going to keep happening. And if they've got cellulitis and it's recurrent, maybe that's what needs to happen. But actually, if it is venous eczema, then if you get in there and you actually diagnose this and you manage this, it's better for the patient. You prescribe this antibiotics, which is all good, but also you're hopefully not going to have that call saying, can I have some antibiotics to treat this problem? So hopefully actually it's going to save you time in the future.
Yeah, so I think that's really good thing to hear. So we are investing time initially, be that in a visit, being that in asking lots of questions, being that in, I guess, there's a degree of education aspect of this as well at the beginning to potentially save us a lot of time down the line, because of course this can be very time consuming. Yes,
exactly, yeah. I mean, again, what will probably happen is you'll get this sorted and then it will save your colleagues some time, but you can't have everything.
Yeah, well, absolutely. So obviously you've talked about the redness and the heat and the unilaterality versus bilaterality, I guess, of this. But I mean, what is venous eczema, and why is this a tricky topic in this respect? Why is it that we're even focusing on this?
Yeah, it is a fairly common problem in our older patients. So the issue we're having there is the circulation down to the legs. The arterial circulation is absolutely fine, but it's the venous return. So we know that can be impaired for lots of reasons. So one of the main ones is the valves don't work as well as they used to. So you've got incompetence of the valves. That causes varicose veins. Then you've got back pressure, and that causes venous hypertension. Because you've got venous hypertension, that then causes leakage of fluid from the veins into surrounding tissues. You then get edema. Because you've got edema and poor venous return, you then don't get good removal of waste products from the skin. You get a slightly hypoxic environment. The skin is stretched by this edema and it's unhappy. So you get this redness and this unhappy environment. And this causes the inflammation, this causes the redness. And this isn't good. Decreased mobility is a big sort of attribute to this as well. This does have a big, this is a big kind of causal trigger, or makes this a lot worse. So we do see that again in our older patients. You see it in heart failure and sort of hip replacements, knee replacements, anything which sort of impairs the lymphatics or affects the venous return, that also kind of impairs this as well.
I mean, so we've got a situation where we're being asked about, is this cellulitis? But actually we quite often see they've got swollen legs. Yes. And there is quite a lot of, I guess there's quite a lot of frusemide used in this respect or similar for it. I suppose just as an aside, is that a helpful thing to use in venous eczema?
I hate this. This is there's it's in my top 5 things that just really irritate me. So my least favourite is amlodipine. We give amlodipine for blood pressure, great, lovely, but we know one of the side effects is leg swelling. And then I've seen quite a few patients where they're on amlodipine and then we give them frusemide to counteract the leg swelling. It just doesn't feel very good. As I would say, stop amlodipine, give them something else. Okay, in certain cases, you're going to be limited options, but actually give them something different. Maybe give them, some indapamide if you can. Then you're going to have that sort of slight diuretic effect, and you're not going to have the side effect of the edema from the amlodipine. For me, I don't think long-term frusemide improves leg swelling. I think short-term it does, but venous eczema, I don't think there's good evidence to show it makes a lot of difference, and actually it makes you wee more, which is irritating for patients. I've had a patient the other day say to me, do I have to keep taking this, doctor? It's really kind of affecting my life. It affects the renal function, which is again a bigger problem, and also then and then it can affect blood pressure, so we could get falls, we get all sorts of problems with people getting up in the night, potentially, again, hopefully in the day, but walking around, going to wee, having AKI as a result of this drug we don't need to give them, and it's actually not very effective.
Yeah, no, absolutely. Yeah, we of course we see that very often. So using things like frusemide, diuretics with caution. We're going to come on to a situation where it could be useful a little bit later on. But essentially, so we've got a bit more of an understanding of why people get this venous congestion. What does it look like when we're actually looking at the leg? What might we see?
Yeah, so when you're looking at the legs, usually, again, if you've got a pair of legs, they're going to be the same. There's probably going to be edema, there's probably going to be varicose veins, there will be redness to the skin, there might be some scale, it might look a little eczematous as well. And as we said, if you feel the legs, and always, if you can put your hand on the patient, the legs are going to feel a normal skin temperature, they're not going to be hot. Another test you can do if you want further reassurance is if you lay the patient down on the bed and you elevate the leg, and you really want the leg quite high up, nearly 90 degrees if you can do it. If by doing that, you're actually then improving that venous return, and you will see within a couple of minutes, a lot of the venous congestion will improve, so a lot of that redness will fade away. It'll come back as soon as you stand the patient back up, sit them back up. But that's quite a nice test. And I have done this a few times. I keep meaning to do a video and I never get around to it. But I did have a patient where there was some good going venous eczema. We elevated the leg, all the erythema settled down, and there was one patch which when you got rid of the rest of the redness was more obvious, and actually it was warm. So they had got a little bit of cellulitis starting up. So it was quite a nice test to show, one, yes, I'm right. I've improved the venous return, and I can see the problems improve, but also there was a bit of cellulitis starting up that we did need to treat. So it was helpful from that point of view.
Because of course, with the venous congestion, with the damage to the skin surface, not only do we have this kind of misrecognized venous eczema, but there's also an increased risk of cellulitis. And trying to differentiate those two things is the real crux of the situation, isn't it?
Yes, yeah. And people, when I've talked about it before, people have said, well, are you sure? Are you sure? And I'd say if you're not sure, treat it as cellulitis. But I always come back to, we know antibiotics are anti-inflammatory. So if you give people a week of flucloxacillin and they've got venous eczema, their legs will look better. It will improve, but then a week or two after, it will be back the same as it was before. And if it's coming back and looking the same, I think then you've got to think about, well, actually, is this venous eczema? Are we not treating cellulitis here? Or is this cellulitis that is resistant? Do they need IV antibiotics? Do they need admission? Just giving them course after course of flucloxacillin, clarithromycin, whatever. Is that really the right option here? Do you want to do some blood tests? Again, there's no blood tests that help us diagnose venous eczema, but at the same time, if you do some bloods and you do a full blood count, an ESR, a CRP, and they're normal, then that to me goes against having cellulitis. I'd expect a raise there, inflammatory markers, if there was cellulitis going on.
Yeah, I guess this is part of the complexity, and I suppose that I reflect when we're talking about this that is a topic that feels like it should be very easy to sort out, but in reality it actually got fraught with complexities, isn't it? So we've looked at the patient and we've seen edema, we've seen some leg swelling, redness, bilateral, maybe we've done some blood tests as well, and we're trying to come up with a bit of a plan, because ideally, if this is going to be a thing that's going to be lasting for a while, we need to be doing something effective about this, because that's the investment that we're hoping that means that we don't have to come back repeatedly for this problem.
Yes. Yeah.
How would you approach that?
So the Wounds UK, if you go on Wounds UK, they've got a really nice sort of loads of papers, loads of work kind of going on about venous ulcers and venous eczema. And they talk about compression. Compression is the cornerstone of management of venous ulcers. And I would extrapolate and say it's the same is true of venous eczema. So the key management is compression. We're improving that venous return, and then that's solving all these other problems. So we improve the venous return, we decrease that venous hypertension, we decrease the edema, we decrease the hypoxia in the tissues, and everything improves. The problem we have is the legs are often quite tender. So if you just try and put somebody straight into compression, they often don't tolerate it. And I've seen this several times. So, and I know some people have thought, oh, the patient's being awkward, but I think it is unpleasant, and if you imagine you put a rubber band around your finger and you let it swell up and then you try and squeeze it, it hurts. So it's understandable. So the approach I take, I can't find evidence to support this, but it seems to work for me. So that's what I've gone with, is I like a short course, assuming you using these are all okay. I like a short course of furosemide, 24 milligrams for a couple of weeks, and that will help get the swelling down. So actually then you can get a more accurate measure of their legs in terms of sizing them for compression. And also I'll give them some topical steroids. So I'd use Betnovate 0.1% twice a day for a good 2 weeks, or mometasone will be equally as good. And those two things together, the furosemide and the steroid, will reduce that inflammation, so the legs are then happier in the short term, so then you can get them into compression.
I mean, compression is a thing that I think a lot of us have heard of, but in terms of actually sort of seeing or experiencing it, it's a regular thing. It's a thing that's happened for quite a long time, and a thing that sometimes ends up turning up in dermatology clinic.
Yeah, so we were just saying that earlier. So I've had patients come to dermatology with venous ulcers, and again, please, if you're first into dermatology, please tell me in great detail what you've done. I've had people referred and they've said, this person's got a leg ulcer and we've tried everything and nothing works. And at that point, I just clearly give up because you've tried everything. But no, please tell me exactly what you've done, for how long, what you've used exactly. That would make my day. But yeah, so we've had patients come to dermatology with venous ulcers, and actually when you get into it, they've not been in compression, they've not had any steroid, they've not had any furosemide in the short term, they've just had a pad applied and then a bit of light cotton wool applied to it. So to me, that's not treatment, that's palliation. That's not treating the problem. It's not going to make it better. And we can do compression in primary care. We can make this so much better, and we know if we don't improve venous eczema, it can develop into leg ulcers. I don't think it's an inevitability, but it is a high risk thing. I feel like we spend a lot of time managing blood pressure, managing cholesterol to try and avoid heart attacks. Actually, why aren't we paying the same attention to venous eczema? Because we know that causes ulcers, we know they are debilitating, and they have a huge cost to healthcare.
Yeah, debilitating, reduced mobility, increased falls, ulceration, and you said before that often you'll see people with, I suppose, quote unquote, chronically infected ulcers, and actually, do we see actually? What do we mean by sort of this recurrent infection? Because a lot of times we'll be sent a swab, or a swab result will come in, or they'll have some antibiotics and they'll say, oh, it got a bit better for a while, can I have some more? And then it's quite difficult to say, no, it helped before, but it's not going to help now. So what would your take on those things be?
Yeah, so it's tricky, isn't it? Because we know antibiotics do have an anti-inflammatory effect, and they do give us some partial improvement for a short period of time. Most venous leg ulcers aren't chronically infected. They can become infected, and it can be difficult to know sometimes, is there kind of an acute or superimposed infection going on, and kind of increased pain or increased leakage with appropriate management. I do get calls from nurses saying, oh, the leg's leaking, and actually if they're just wrapping it and it's not in compression, we need to nurse this, we need to manage this appropriately. Just giving some antibiotics isn't going to help this in the longer term. So in those cases, yes, it could be infected. What about doing a swab? So don't routinely swab leg ulcers if you're suspecting infection, and by that I mean there is a change, so increased exudate, increased pain, warmth, those kind of things, then not unreasonable. But we also know swabs generally aren't that helpful, because you swab some skin, you will find some staph or some strep, and that doesn't necessarily mean there's an infection there. We often find coliforms on leg ulcer swabs. Coliforms, in my understanding, don't usually cause infections in leg ulcers. We don't need to give these people metronidazole. This is colonization. This is a dirty leg, essentially, and that probably comes back to kind of nursing care, really. We do need to wash these. We do need to clean these, and dress them appropriately to clean them and keep them clean. And I often say to patients, if they're feeling antibiotics are the answer, I'd often say, well, look, we've done antibiotics this many times and this hasn't got better. So, actually, can we try something different? How about we try my idea and see how that goes? Or I might say, well, let's try antibiotics and try what I'd like to do. But it can be difficult sometimes to get out of that, what's been happening. But if it's not working, we are where we are. I think it's good to try something different.
Agreed. I mean, and throughout every time I've heard you speak on this topic, and throughout this idea of getting compression and effective management is so important. I think that we fall into habits of recurrent antibiotics, which of course gives us lots of risks. But actually, compression sounds like the method that's going to be most useful in this situation.
It's the Wounds UK. It's the cornerstone of the management of venous ulcers and venous eczema. And I suppose coming back to that, getting compression started. How do we do that? So it's going to vary from practice to practice. Class 1 compression, you can pretty much start on anybody. My caution would be if you've got somebody with known peripheral vascular disease, smoke, heart attacks, erectile dysfunction, diabetes, okay, be a little bit careful in those people. But if you can feel their pedal pulses, and again, accounting for lots of edema, then you're probably okay. You're probably fine to start that. And the class 1 compression stockings are 14 to 17 millimeters of mercury. That's not a lot of compression. If you're really, that's, if you're able to sort of decrease someone's circulation sufficiently to cause an arterial ulcer with that level of compression, they've got critical ischemia, and you'd hope that's kind of evident. You hope we would see that in other ways. It wouldn't just be by the fact you apply compression and things seem to worsen.
I think that's helpful to know, because I think a lot of people really worry and might delay compression because of worries. I can't possibly do anything until we've investigated this further. But for patients that don't have evident limb ischemia, of course, being careful in that respect, we can make some changes initially. How about, I suppose, later on, if we're looking at kind of proper compression, shall we say?
So I would say get the class 1 compression started. You want the legs measured. Your nurses can help you with this. You can do it. If you Google the brand of stockings used, you can measure the calf and the ankle and get that started. That's absolutely fine. It's a bit hard to find the stockings sometimes on EMIS System 1. Wounds UK, they say about start compression and have an ABPI within 2 weeks. I would like to work where they're referring to, because I can't get one within 2 weeks. So if you want to go for high levels of compression, so class 2, then you do want to have an ABPI. How you get that will vary locally. We used to do them in practice. I think in Nottingham now we're not doing those. It's going to vary across the country. So some places it's going to be the district nurses or the district nurse base. There might be a wound clinic. It's something vascular might do. Also, kind of if there's a leg ulcer clinic, again, they might decline if there's not already an ulcer. But ask your nurses, they will know how to do this. So ABPI, if that's normal, which is a reading between 0.8 and 1.3, you can get them in class 2 compression, and that will improve things further. But I would say if you do the furosemide, you do the steroid, get them in class 1 compression, you make me incredibly happy, and that's a gold star from me if that has any value to us whatsoever.
And I think enormously appreciated by patients, because having chronically inflamed, red, sore legs, and swelling and the leaking that comes with it must be very, very unpleasant. And I think if we can make better assessments, and if we can make better better management plans for patients, including prevention being better than cure. So at the early stages of this, talking about elevation, exercise, light compression, to prevent us having to get up the higher end. This is all real important. It is all really important.
And as you said, once we get to leg ulcers, that's really debilitating. Just from the point of view, is you've then got the 2-layer compression bandages. You can't get in normal shoes. How do you get out? What are you going to do?
Absolutely. As we draw to a close for today's podcast, I think that's a really good take-home message. I'm certainly going to be like, let's ask more questions. Let's find out what has happened, and some of the details around it, photographs and history. So that feels like a thing I'll take away. Have you got any more advice you might share with us if we really had a couple of things for people to take away from today?
I think starting the compression is the most important thing. And don't be afraid of class 1 compression. You can start that if they've got pedal pulses, and if they haven't got big vascular risk factors or obvious claudication, that's absolutely fine in 99.9% of cases. Kind of with that, before you start the compression, or on that day while the pharmacist is ordering the stockings, give them the furosemide for 2 weeks, give them the steroid, the Betnovate 0.1%, or the metazone for 2 weeks to improve that leg, get the redness down, get the swelling down, and then when they start that compression, they'll be so much more comfortable, they will tolerate it, and hopefully they can carry that on. And then again, it's hard to prove it, but you'd hope then you're going to prevent a deterioration of his legs and prevent them developing an ulcer, and it's also going to prevent them ringing you for antibiotics, which is good as well. So for me, that's kind of the key. That's what we want. That's the goal of my management.
And brilliant. And I love the fact that there are such sort of simple and straightforward things that we can do for such a impactful topic to us clinicians and general practitioners, such an impactful topic to patients as well, which causes so much misery and avoidable problems. So it's been really wonderful talking to you today, Dr. Graham, and hopefully people listening at home will feel much more confident about seeing patients, not being scared of compression, and managing this really, really important topic.
Yeah, absolutely.
Thanks so much. Thank you for your time today, and we look forward to speaking to you again. We've got other dermatology topics lined up, but thank you very much, and thank you everybody at home for listening. Take care until next time.